Hello everyone, and welcome to California WIC Association's WIC Works webinar for November 30th. We're going to be talking about nutrition preventive services, existing gaps, and a critical ACA benefit. We're glad to have so many of you with us this morning. My name is Margaret Aumann. I'm the CWA Communications Coordinator, and I'll be joined by Karen Farley, our Executive Director. Just wanted to let you know a little bit about California WIC Association if you're not familiar with us. We're a nonprofit education and advocacy organization supporting the WIC, Women, Infants, and Children Nutrition Program in California, but also doing education and advocacy nationwide. We're on the web at calwic.org. If you haven't visited us before, we hope you do, and we appreciate your support and invite you to become a member if you're not already, so that we can continue offering educational opportunities like today's webinar. Just a few logistical things before I introduce Karen. All of you are in listen-only mode, so just a reminder about that. If you do have a question, please type it in the question box or the chat box. We'll be relaying those questions to the appropriate presenter as we go along, and there'll be a couple main times to do that later in the webinar. We invite your questions by all means. We are recording the webinar, and you will receive a link to that recording tomorrow in case you want to share it with other people or can't stay for the whole time today. For those of you who are interested in earning 1 hour of continuing education, whether you're a registered dietitian or a lactation professional, you will receive a link tomorrow to the evaluation that you'll need to fill out. It's also required that you participate in the entire webinar. We do have a way of tracking that, and only if you registered in advance for the webinar. Some of you may be all grouped around a computer and listening together. If that's the case, and so our records won't show whether you attended, please email me a list of those of you who are in the room, and we'll make sure that you get credit. I also wanted to mention that our information will be posted on our website after the webinar, both a link to the recording, the slides will be posted, and some references to Karen's presentation. So if you have any questions throughout, again, please type them in the question box. We'll be happy to share them. I have the privilege of introducing Karen Farley, our Executive Director at California WIC Association. She's a registered dietitian and IBCLC who has lots of experience and has worked very hard in the area of preventive services, preventive nutrition services, and the ACA. So I'm going to pass the baton over to Karen, and she'll get us the information that you all came for.
Thank you, Margaret. And let me open here. Is that working?
Looks good.
Okay, so thank you all for joining us. As Margaret mentioned, we are the member services for the 83 local WIC agencies, and we support the mission of WIC. But another area where we have invested quite a bit of our resources is in the larger infrastructure for nutrition and breastfeeding support in the communities. And before the ACA was passed, and there were a lot of conversations about healthcare reform, we started really looking at beyond WIC, how can we support families for breastfeeding, particularly because that seems to be an easier one to tackle, but also for nutrition preventive care so we can have good health outcomes. Today we'll have a few references to breastfeeding because it definitely ties into the infrastructure of what we're talking about, but mostly we're going to talk about nutrition. So we do have the Affordable Care Act, and even though it's in a new position now with the election and there's a lot of questions about it, it is here, and there are some opportunities for nutrition and breastfeeding. We're talking about the preventive services, which are in Section 2713 of the Affordable Care Act. So just a brief history, the Affordable Care Act was passed in 2010. verified again or upheld by the Supreme Court in 2012. And then some major things had to happen to establish the beginnings of the Affordable Care Act. States established state exchanges. In California, we have the Covered California Exchange where people can buy insurance. We also had a lot of Medicaid expansion so that we can reduce the uninsured rate. And so with those two things, we also have to deal with cost, and the organizations implementing the aspects of the Affordable Care Act really had to address high-cost patients to help start bringing down the out-of-control healthcare costs, and also try to get young, healthy participants, members enrolled in healthcare. So prevention, although it's part of the Affordable Care Act, was not top of the pile of things that needed to happen, and infrastructures need to be built, and some of the really high-cost issues needed to be addressed. So that work has been going on for a number of years, and prevention is still very much there as we know the Affordable Care Act today. But in addition to the Affordable Care Act, there is health care reform, which is much larger than the Affordable Care Act. And we believe from our research that no matter what happens to the Affordable Care Act, health care reform is here to stay. And there are some basic tenets regarding health care reform that are important for us as nutritionists. And one is the triple aim. And hopefully you're familiar with these concepts, but we really do have to work on the population health improvement and reducing per capita cost, and also improving and changing the experience and care of the patient. For today, we're going to talk about the U.S. Preventive Services Task Force recommendations around nutrition preventive services and some concepts in healthcare reform and partly in the Affordable Care Act that we hope are still entry points for us, but as nutritionists, we really need to be aware of and be knowledgeable and advocate in certain areas. So we asked the question, CWA, California WIC Association, asked the question, what nutrition support is available? And first we went to our own health plan benefits and we looked for what is there for nutrition support. And quite frankly, we didn't find much. Some plans mentioned nothing, some mentioned pamphlets, some mentioned a phone line you could call, but we really couldn't get a sense from a consumer standpoint that there was any standardization of what do I get as a member. Do I get to see people in person? How many visits do I get? What's determined for my benefit? So we decided to do a broader literature search and find out what anybody was posting about nutrition support and the direction it's going. We also consulted with national nutrition experts. We identified what nutrition support services are existing. And then we held a statewide California meeting. So we're going to talk to you about this work today in these slides. So we conducted a literature search and we found just a few organizations had really written about the Affordable Care Act and health care reform, and in not super great detail. But the Association of State Public Health Nutritionists and the HRSA branch of Maternal and Child Health Bureau had really written the most detailed documents. The American Academy of Pediatrics has a document which we'll show you later, hopefully you've heard of, called Bright Futures, which is a guideline for providing nutrition care. And the Academy of Nutrition and Dietetics, for those of you that aren't aware of that, sort of the national organization for registered dietitians, we couldn't find any real solid documentation of the preventive services. It was more generic material about prevention. And then AMCHIP, the Association for Maternal and Child Health Programs, has documented facets of healthcare reform, the Affordable Care Act, as it's rolled out. So looking at these documents, this is what we found. We found that there are some issues, and so you think about, we're going to learn about this one topic, and when you start digging it becomes broader, and we are talking about what is the national infrastructure for nutrition support services. So it stands to reason that there are other aspects that need to be also there to make this a viable benefit for health plan members. So looking at workforce and training, we found some issues, basically silos. Public health nutritionists and a focus on prevention and clinical care are all very siloed when it comes to nutrition care. There isn't a lot of interlocking coordination and collaboration. And the funding sources, the employers for nutritionists, are also siloed. MCH is really one of the first sources of nutrition care for our nation, and that's housed in the Federal Health and Human Services. WIC is in USDA. And then clinical care is housed in hospitals, medical groups, and private practice. So we would hope that when we think about an infrastructure, all of these systems and professionals actually coordinate. Looking at the MCH funding, which is Title V, that funding is always stretched very thin, and those professionals do a lot with very little. And there's actually a declining focus on nutrition. We used to see a lot of public health nutritionists in communities in addition to WIC, but that funding just isn't there. We're happy to have what we can get, but Title V has never been as robustly funded as we would wish it would be. And then there are a declining number of public health nutritionists, those who do focus on prevention. And there are some issues around that. We need these public health nutritionists to have some really strong strengths when it comes to leadership and understanding policy and systems change. We need to have our nutritionists understand population health, not necessarily just individual case management. And for nutritionists, internships are very hard to come by for those who want to become registered dietitians. They can be costly and there aren't enough slots. We need organizations to take interns so that they can get that critical training. We're also concerned that there's a shortage of culturally and linguistically competent public health nutritionists or public health nutrition educators, whatever level of expertise they are. We have a very diverse population, particularly here in California, and we really need a diverse workforce. We'll provide much better patient care if we have that diverse workforce. And now there's a requirement that entry-level, or it will soon be a requirement that entry-level dietitians have a master's degree, and we're concerned about what kind of impact that will have on public health and prevention outcomes. The literature also showed, particularly in the AMCHIP, or the ASPEN and the HRSA maternal child health documents, a reference to the essential health benefits. So hopefully you're familiar with these. This came with healthcare reform, and this are the basic health benefits that health plans are supposed to provide. And there are two entry points for nutrition here: maternity and newborn care, and prevention and wellness services and chronic disease management. Hopefully these will persist as healthcare reform and Affordable Care Act gets looked at in the next few years. We would hope, we would all argue that from a business standpoint, good nutrition support will result in healthier, better health outcomes and reduced costs and a better return on a business's investment. We also looked for what kind of nutrition support guidelines were there, and we didn't find much. As we mentioned, the Academy of the AAP, the Pediatric Academy, has Bright Futures. And that gives guidance on nutrition counseling and some amount of periodicity as far as when that counseling should happen. But it's not specific as far as a health plan's guidance. And then before the Affordable Care Act was passed, we often reference in our work, mostly for breastfeeding care, this document, A Purchaser's Guide to Clinical Preventive Services, Moving Science into Coverage. And this is a document from the National Business Group on Health, also known as the Pacific Business Group on Health. And they have a lot of materials that an employer would use when they're thinking about what are the health plan benefits that I'm going to contract for. So then we consulted with national nutrition experts, and you can see on the screen the experts that spoke with us, and we appreciated their input. We had the National Academy, the National Organization for Registered Dietitians, Academy of Nutrition and Dietetics, and the California contingent. We had the HRSA, the Maternal and Child Health Bureau, both the federal level representatives in some regions, and we had the Office of the Assistant Secretary of Health, OASH. We also had ASPEN, the State Public Health Nutritionists, the National WIC Association, representation from the U.S. Breastfeeding Committee, our two health departments here that house both MCH and Children's California Children's Special Services for special needs, children with special needs, and our health financing department where Medicaid comes from. And then we had some state representation, the Oregon Health Authority, which are doing some really dynamic work around healthcare reform and healthcare benefits, and Washington State Public Health Department, New York WIC, and then ourselves. So what did we hear from them? Here's some of the issues that came up. The ACA is not clear about rescreening, referral, and care. Who will provide this? There isn't a lot of definition in the law, and some of this is to allow states and health plans to define that and not be too prescriptive. But then it becomes confusing as far as what that benefit relates to and what the health plans are going to provide as far as those referrals and payment systems and who's going to be allowed to do the work. The CMS, the Center for Medicare and Medicaid Services, issued a rule almost 2 years ago now that states can request a state plan amendment to allow unlicensed practitioners working under a licensed provider to provide the preventive services. And that's an opportunity for unlicensed practitioners, whether they're nutrition or RDs or nutrition assistants, to provide nutrition care. There's also in the Affordable Care Act the requirement to use community health workers, and the scope and practice and training of that hasn't really been drilled out, and there would be opportunities there for not only RDs but individuals who are not going to have an RD or maybe a degree nutritionist or a nutrition assistant to provide that care and probably provide a much more robust and diverse workforce. And then there's an opportunity in the Affordable Care Act for coordinated care organizations, and these are different in different states, but it allows for community care and new payment systems and patient-centered care to improve the health care for patients. Some other things we learned was that WIC has a national infrastructure of workforce and buildings where people can come and get services. In some what about ideas, what if the WIC staff working with their parent organizations, which are generally health departments or nonprofit organizations, were to use their staff to work with community health centers, health plans, medical groups, and we could expand that nutrition workforce in the communities so that we could serve many more families and have a better, robust nutrition support system. We also talked about it's important to measure value. How do we show those good outcomes for nutrition intervention? And to do that, we need data and QI. And it looks like we really need to get more entry into electronic health records, which has quite a bit of complexity with different programs being used and access to fields and asking standardized questions. But data and outcomes is really important for all programs, and we certainly need to show the value of nutrition. So then we looked for what are nutrition support services. And mostly in nutrition, historically, it's been medical nutrition therapy, a very clinical approach to nutrition focusing on a few key areas, diabetes, renal care, hospital-based care for pathology. But the Affordable Care Act and healthcare reform is really focusing on prevention. There is a program, Healthy Start, that's funded by HRSA, a federal program, and that takes care of pregnant women. And there could be an entry point there to use RDs or other nutrition experts to serve in that population, and maybe that can be built out as far as a way for another service and billing option for breastfeeding, for nutrition. We also need to see, and there are some examples of RDs that are integrated into primary care. There are some examples in California, and there's an example in Washington, the Yakima Valley Health Clinic, where RDs have, before healthcare reform, been integrated into the team care, but we need to see more examples of that. Here in California, long before the Affordable Care Act or healthcare reform was implemented or even dreamed of, we've had an expanded Medi-Cal program called the Comprehensive Perinatal Services Program. It's kind of a mouthful, but it's a team-based approach to care that includes a registered dietitian, but it also includes openings for other non-degreed staff and non-licensed staff to work with moms for nutrition and breastfeeding and health education. And that is a specific Medi-Cal program, but that model is a model that would be very useful for other opportunities for nutrition care, whether it's dealing with other populations or other age brackets, but that's a model that California is very proud of. And then we found a few examples where health plans are providing nutrition care, but they don't call it preventive services. So when we say what are those Affordable Care Act preventive services, we did find a couple examples where care was provided, but the health plan didn't consider it to be part of that. They were just doing it because it was the right thing to do. So all in all, these are a few examples of what we would hope to find on a state level or a national level. And so there's work to be done as far as expanding that and expanding those opportunities. So this webinar is titled Gaps. Are there gaps? Yes, lots of gaps. Are there good ideas? Yes, good ideas. So the last thing we did was we held a statewide meeting here in California. And we were able to bring together over 30 organizations that included public, state, and federal organizations, private, nonprofit organizations, and programs. And we looked at a few, we tried to drill down to some more granular details as far as what we've been hearing and what we were seeing here in California. We looked at workforce capacity, WIC and public health collaborations, business and care opportunities, and payment reform. So I just want to share with you a little bit about what we have found here in California. So regarding our nutrition workforce capacity, there are opportunities and there are challenges. The opportunities that we see are that we need to allow more opportunities for professional development and diversification. WIC staff, as far as the ones we've been informally polling, are interested in expanding their opportunities into the areas of certified diabetes educator or life coaches or health coaches. Offering opportunities at different points in people's career gives them something fresh to think about, and from a nutrition standpoint, it makes us more valuable team members in the healthcare team. We need to have career advancement. WIC has excellent models for career advancement for both lactation and nutrition. People can advance from peer counselor to lactation educator to lactation consultant. Similarly, we have nutrition assistants, we have degreed nutritionists, we have registered dietitians, and we have individuals with master's degrees. Some people want that career advancement. They're going to take the time to get their degree while they work. They love the work that they're doing in the community, and people need to have those opportunities. We also need living wages. Nutrition has never typically been anything you do for the money, but we need living wages, and this is a huge concern in California because rents and mortgages have become very untenable, and we know this is an issue in other states, but we need to be able to support people so that they will stay with the profession and stay in their community. And then, as is mentioned before, we need to have a really culturally and linguistically strong workforce. And to do this, we're going to have to allow different levels of professional advancement and expertise into providing nutrition care. We're going to need to allow individuals who might be called paraprofessionals or peer counselors or community health workers along with registered dietitians so that we really have a robust workforce. There's also some opportunities with our WIC parent organizations. So WIC as a program is federally funded through the USDA. It is not going to contract out its staff, but these staff work for a parent organization that has a WIC contract. These staff can contract outside of their WIC time through their parent organization to work in the community. And they are the national nutrition workforce everywhere in every community in the country, every county in the country. And we have examples here in California where they contract to community health centers. There's a few that are started to contract with health plans, and then there's medical groups where we could be serving both the public health population and the population that is not eligible for WIC. And then we can also serve diverse nutrition needs. Although WIC is skilled in maternal and child nutrition, we've already had organizations talking to WIC staff about, well gosh, we have seniors who need nutrition counseling, we have men who need nutrition counseling, we need nutritionists, and we need people who can talk about nutrition. So those are some opportunities that should be considered. And then there are business and care opportunities, and mostly what we've seen, this is around agreements with health plans or DMEs to manage breast pumps. Breast pumps take a lot of management as far as cleaning and inventory and issuing, but there are opportunities to help the ACA provided pumps and education around breast pumps and breastfeeding to be partnered with, again, in one example, the WIC workforce working outside their WIC contract, and make sure that our nutrition, or in this case breast pump and breastfeeding support network in the community, is strengthened. WIC has always been the default for breastfeeding, but and the health plans are looking for partners. So how about it? How can we figure out some ways to be partners? And WIC agencies in California have figured that out. And then finally there's payment reform, and this relates to the Affordable Care Act and also health care reform. And this is something we all need to continue to be more knowledgeable about, or first of all, think about and learn about. Some of us are just learning about this for the first time. So payment reform is quite complex, and there are a lot of aspects to it, but just a few things that I wanted to point out today. Payment reform and healthcare reform are really looking at social determinants of health. How do we lift people up, keep them healthier, help them from getting sick by addressing social determinants of health? You may have noticed some of the health plans are funding housing options for patients. Who would have guessed that a few years ago? Well, social determinants of health definitely includes nutrition, whether it's food insecurity or access to healthy food or obesity or physical fitness. We should be in there when it comes to social determinants of health as a really valuable part of the healthcare team. Another part is patient-centered care. We have a lot of experience in patient-centered care when it comes to the hospital and in public health. So now as we look at patient reform, we need to advocate for ourselves as being part of that patient-centered team, using motivational interviewing and really working in skillful ways with patients so they can determine their own health path and help themselves stay healthy. We also have had experience and really need to promote ourselves as part of team-based care. As I mentioned, that expanded Medi-Cal program here in California works off team-based care. And a lot of the certifications reform that are happening in health centers, which is ground zero for healthcare expansion, is team-based care. Local health centers can get certification as participant-centered medical homes. So there should be opportunities, and we should be at the table reminding and advocating for ourselves as being part of that team-based care. And as we mentioned, we need to focus on outcomes, and we need to show what outcomes we have. WIC has outcomes for, it's been in the news in the last few years that WIC's been able to impact childhood obesity between our counseling and our food package. Well, we need to show those outcomes because that will help us be invited to these discussions and be included, because health plans and health management organizations want to see how we can get healthy outcomes. And that ties in with pay. And there's an increasing focus on pay for outcomes, pay for performance, value-based purchasing. So we need to show that we can contribute to business outcomes by being part of their team, and we are a good return on investment for these organizations that are providing and paying for health care. So after all of this, we have some recommendations. So we did not find huge systems change for nutrition. We didn't find, oh, there's a big nutrition support network out there and health plan members can just, you know, click on the online and get some nutrition counseling. It's very sporadic, as you're probably more familiar with. More has been written about breastfeeding support, but there are a lot of things that need to be done for nutrition. So in thinking about that, those ways and entry points for helping create that system, these are our recommendations. We need to work on relationships and collaboration, and this isn't necessarily a huge system change, but it certainly helps. Even in our big state in California, we value those individual examples of relationships, and we share them out to show what other companies, other organizations can do when they get to know each other and learn how to work together. Collaboration is a buzzword now, and it really makes good business sense for everybody. So relationships need to be built, working relationships, not just knowing who each other are, but working relationships and business agreements and collaborations, MOUs, service agreements, whatever it is called, between health plans, community health centers, medical groups, and WIC. There are lots of ways, we've shared a few of those today, where these staff, these experts in nutrition, these new concepts in healthcare reform and the Affordable Care Act can be creating new ways to provide good, healthy patient care so that we can get those reduced health costs, better patient outcomes, and a better patient experience. We also need some good documentation of what is good nutrition care, periodicity, how many visits, when, who does the person see, what kind of a visit, is it individual, is it group, are we going to use technology, what do we have here, what's the reimbursement rate, how much time should be spent on each visit, that operational information, we really need that. If anybody has that because we haven't discovered it from other states or anywhere, please share that, because those kind of documents are really helpful when you're trying to make change either in your community or in your state. And that brings us to, we need to share what works. We've provided some examples today of some nutrition support programs that are out there. We need to figure out how to share that more widely, either by having webinars or having national organizations or key organizations post models, case studies, videos, whatever it is, outcomes data about how programs are working integrating nutrition care into healthcare. We need to have some innovations, like the examples we shared today with nutrition staff working integratively in their community. We don't necessarily have to change whole systems at once, but those individual programs can really start the wave of change. And so we need communities and organizations to commit to that, to calling up their co-organizations in the community and saying, let's try something new. And when we do that, we need to collect data. A lot of that will be in the electronic health record and accessing those fields like you see here, identifying the fields, allowing people to access the fields, asking the right questions so that data can be inputted and then queried out so that we can show that nutrition support is working. And then finally, we have some issues around training, registration, and multiple levels of nutrition expertise. We need all kinds of nutrition expertise. Some people need some basic nutrition education. Some people need more advanced information. Some people need advanced clinical care. But we need everybody if we're really going to support our populations in the most cost-effective and management-wise way so that we're assigning the right people to the right patient need. We'll also have a more diverse and robust workforce that will be able to address the needs and speak in a competent and culturally appropriate way with our diverse population. And for those that do need internships to be registered dietitians, we need more. Organizations need to volunteer to invite degree nutritionists in so that they can get their internship hours in their organization and become registered dietitians. We also have a lot of degree nutritionists here in California that need positions, and there should be opportunities for these individuals with 4-year college degrees to be working to support nutrition in the healthcare field. This picture on the left is the 2015 California Nutrition Corps Scholars, and this is a scholarship supported by General Mills for many years through the California WIC Association. In California, the California WIC program coordinates 5 and supports 5 internships where individuals are allowed to get their internship and then go on to become a registered dietitian. And this has been a very successful program, but it's really maintained individuals who have a lot of understanding of their communities, their cultural diversity. There are more young men joining, and these are the kind of opportunities that we really need to promote to keep our nutrition workforce strong. And then lastly, there's coordination between the nutrition professional groups. As we mentioned, we have individuals in MCH, we have individuals in WIC, we have individuals in clinical care. And our professional groups or organizations, our larger structure, really needs to reach across. There's more strength in numbers. There's more value when we act in a coordinated way. We identify our strengths and our ability to reach across. So we really need to work better in some sort of systematic way to bring our larger nutrition workforce together. So those were our findings, the strategies we used to get that information, and our recommendations. We welcome any information that you might have that could be useful that we can learn from, and we ask you to share that with us either through the webinar today or sending it to us by email. So thank you for listening, and this is our contact information. And what questions do you have?
Thank you so much, Karen. Yes, there are gaps in nutrition preventive services. That's very clear, but you've also given some great examples of how to start closing those gaps, as well as pointing out what we all need to do and how we can all step up to start closing those gaps. We invite your questions or comments right now. If you could type them into the question box or the chat box on your control panel, and I will forward them to Karen. Now is a good time to do that. We can also do it at the end of the webinar, but hopefully you've been formulating some questions, and we welcome those now. Don't see any right away, but if you are inspired in the next few minutes, by all means, go ahead and type in. Is there anything you wanted to add, Karen?
No, I think it covered it, but we're always interested. You know, we're a big country, so if people have information to share with us, we're very interested.
Great. So given that we don't see any questions just now, we can move on to the second portion of our webinar. But you are welcome to type in a question at any time, and we'll take them as soon as we can. I'm going to talk about a new tool that we're planning to share in the near future, and you guys are going to get a sneak peek at a new presentation platform that is related to preventive services. I'm still not seeing any questions, so I'm going to go ahead and start on that. All right. So this is the first dashboard you will see, the first screen you will see if you were to use our presentation platform. And as I said, we're still figuring out the best way to share it with you. But this is something we've been developing over the last year or more. It is, you may have seen something familiar, something similar that the Office of Women's Health has developed for the business case for breastfeeding. It's basically a tool that you can use for presentations, training, education with a variety of audiences, and it's quite adaptable because it's really just a complex collection of PowerPoint presentations, but they're hyperlinked and presented visually in a way that your audience can't necessarily tell that you are just picking and choosing and customizing it for them, but it can be a great tool. Ours is really just in its infancy, but I'm just going to do a little show and tell so that you can see where we're headed and what might be useful to you. So at the bottom here you'll see that we have several topic areas, and each of these buttons is linked to, I mean, it's not sort of works like a web page, but it's really just PowerPoint. And you can link to any of these topic areas. I'm going to take you first to the healthcare reform dashboard. And here you can say there's several subtopics: prevention, business, service delivery. And each of these buttons is a space where a slideshow can be that you can then link to. So one of the things Karen was already talking about today was the triple aim. So we have a slideshow that describes the triple aim, and there are speaker notes that go with this, and we will share the speaker notes over time as well. But you can pick and choose, or you can go sequentially with these buttons on the bottom of your screen. Hopefully you can see those. And you do an introduction of the triple aim. You can talk about how insurance is evolving. And then we have some slides on how WIC is built on the triple aim, even before that was described or defined, because it's a prevention program. And so we can show the one aspect of the triple aim is better outcomes, better health outcomes, and how WIC has been shown to decrease preterm births or childhood obesity, and also increase breastfeeding rates and consumption of fruits and vegetables. And there's, this is how you can present your data in a visual way. Another part of the triple aim is a good patient experience, and we can talk about how WIC is very much into building that relationship with patients and participants in the program. And then the third aspect of triple aim is lowering the costs, and we can talk about how WIC's connecting people to social services and better nutrition and medical care can actually lower healthcare costs. So it's really integrated into the triple aim, and this is one way you can visually show that. I'll take you back to the healthcare reform dashboard and give you another example. In breastfeeding care, we know that it takes a village to support breastfeeding success, and it starts prenatally, of course, but we have talk about how hospitals are becoming more supportive of breastfeeding, especially because of some California legislation that encourages that. We can talk about how WIC is another part of the village and the continuum of care for breastfeeding support. And talk about how the WIC formula restrictions for initially postpartum help to support breastfeeding. Work sites, lactation accommodation, and show other resources, and talk about how that is part of the continuum of care when women go back to work. And of course, a big part of the continuum of care is community health centers, and you can use this platform to talk about that with your audience, depending on who they are. And then we can jump, even from here, we don't have to go back to the original dashboard. We can jump to another topic, such as WIC. If you have an audience that needs to know more about the WIC program, how it came about, we have a little slideshow on its history over the last 40+ years, how the focus is on women, infants and children, pregnancy, postpartum, up to age 5. I'm running through these, especially for those of you who are very familiar with the program. You can hopefully start to get an idea of how you might use this, and remind them that it's effective public health program. It's good return on investment, and we've embedded in this slideshow some research documents, and we'll hope to do more. But you could open the document from here and take your audience directly to a document, and they could find out where to find it on the web. I'm not going to take the time to do that now, but you could also remind them that WIC now serves about 60% of all infants in California. And so that's the kind of thing that when I've used this platform to present to varied audiences, they're often, it can be very eye-opening to them. And you can see it's very visually oriented, and that's the whole approach of this type of platform. I'll just mention that we received training from Aspire Communications for this kind of thing, and putting it into practice as we go along. I'll just mention this, another thing that, another quick slideshow to show what WIC actually involves, and that's a nutrition prescription. You can talk about the food package. Mentioned breastfeeding support is a very large part of the WIC program, nutrition education for parents, and that impact whole families and communities. And it's another reason it's effective is because of the referrals to social and medical services. So I've just given you a sneak peek, like I said, of this presentation platform. We're offering it to you as a tool. It's still, like I said, under development. We're still building it out and trying to discern the best ways to share it. But if you are interested in it and knowing about how to download it, how to access it, how to customize it for yourself, we want to hear from you. Like I said, our goal is to have it on our website or in another format so that you can download it, get companion resources such as references and speaker notes. So I'd love to hear from you if you're interested in accessing this tool. I don't have a slide with my email address, but again, CWA is at calwic.org, and my name is Margaret Aumann, so my email is MAUMANN, or if you email Karen, she can get it to me. So I invite your questions about the platform or anything that Karen presented. I see we do have a couple questions coming in, and we'll review those now. All right, here's one. I'm just going to read it. It says, being a public health nutritionist is a dead-end job. How do we create a more open workplace? I have been a public health nutritionist in WIC for 10 years, and there are no senior public health positions. The only way to get a higher salary or senior... sorry, it wasn't clear how that was going to end. At my age, I would advise younger nutritionists to get out of the field to advance in salary. So we'll be curious if anybody has some comments on that. Please type them in. Here's another comment. I love both these presentations. I look forward to the recording so that I can share this information with my colleagues at state level Oregon WIC. Thank you, Cheryl. She has another inquiry. I would love to know if other WIC programs have obtained OA or special project funds to support uptraining of dietitians to be life coaches or diabetes educators. So if anybody on the webinar has information about that, please share it out.
I wanted to comment on that question about training. We have an example here in California where a WIC agency, by working with their health department and again these collaborative service agreements, is able to offer diabetes education for her staff, not through a WIC grant, which obviously wouldn't be possible, but because her staff are now valuable members to that public health department system. And so that system is finding the funding to allow her staff to advance in their diabetes education. So that's an example of, I think also to that first person's question who is frustrated and disappointed with her career, of trying to find new opportunities, things that didn't really exist before, where we can allow professional challenges and development for our WIC staff. Or for any type of nutrition professional. It doesn't have to be just in WIC.
Great, good reminders. Yeah, it's exciting to hear about those cross collaborations that help get other funding streams to support staff in many areas. Cheryl asks Karen, says, Karen, thank you. Would it be possible to share collaborative service agreement template? Good question.
Yeah, some of the agencies have those to share, and we can ask. We're starting to see more and more models. You can understand there's county-based WIC, nonprofit-based WIC, health centers that are county-based, health centers that are private, and then there's health plans. So there's lots of different organizations and business models, but we have a few that have been shared, and we can ask the other organizations that are coming on board if they can share. Yeah. Just to mention, sometimes in those agreements, people get stuck on certain words. Is it a contract? Is it a business agreement? Is it a service contract? Is it a memorandum of understanding? And I guess if you're hitting roadblocks when you're trying to set something up, I would say try different words, because sometimes certain words open the pathway forward and other words seem to hold things up. Just something we've learned from talking with different groups.
Other questions or comments? We might be able to put, Cheryl, we might be able to put you in touch with the folks in those specific agencies. We can follow up with that, I think.
Something we didn't talk a lot about today, we talk a lot about it in WIC because WIC obviously only deals with younger moms, and they have a lot of expectations about using technology. But it does seem like as healthcare providers, nutritionists, we need to embrace technology. And if we don't have a huge workforce, or we don't have all the culturally and linguistically appropriate people in all areas, we should be learning from the medical world about how to become part of a workforce that can reach out through telemedicine to remote areas, underserved areas, and those are a different type of agreement that could be set up. Sometimes the challenges there are with the either the health department or the agency that houses those professions as far as permissions to communicate and confidentiality issues or IT issues. But healthcare has gone ahead in this, and we have to learn from them, and we can't take no for an answer when it comes to these barriers. We have to be able to do this, and the more we learn about this, the more we say advocate strongly and reach out beyond your own organization. And when you go in community health centers or even in a medical practice, you see telemedicine happening. So let's learn from that and make that an opportunity for nutrition.
That's great, Karen. Yeah, I think certainly that could be a whole nother webinar, right? The whole technology use and opportunities, and some of it's still very much in its infancy, of course, when it comes to WIC, but we're hopeful that that will be part of the wave of the future. I don't see other comments or questions at this time. So I think we'll wrap up for the day and thank all of you for joining us. Remember, if you're interested in earning continuing education for today's webinar, you should look for the follow-up email tomorrow, and it will have links to survey and recording for everybody. So you can evaluate it, and we welcome your feedback. Again, we hope to hear from you if you're interested in learning more. And thank you for joining us today. Thanks so much, Karen.
Thank you all.